Hi, my name's Kate Ewington. Some of you may already know me from the social media groups set up specifically for slipping rib syndrome. I'm looking to hopefully do a series of interviews, Q&As with people that are very knowledgeable and learning more about slipping rib syndrome. So without further ado, I would like to introduce my first guest, Dr. Abbasi. Could I just ask you to do a quick introduction of yourself for the viewers?
So my name is Ali Abbasi. I'm a consultant musculoskeletal radiologist. My NHS practice is based at University College London Hospital, and I have an interest and passion in scanning unusual ribs and chest wall problems.
Fantastic, and that's exactly what we're here to talk about, aren't we? So slipping rib being the condition in question. I have that myself, and in reality probably have had it for 2 decades, but become very chronic with it about 3 years ago. So your obviously radiological inputs and kind of deep dives into this is really super interesting, and I think a lot of people on the social media groups that I'm involved in would be really interested to hear where you're at with it. So could you tell us a little how you became more knowledgeable and informed of slipping ribs, or how your journey started?
Sure. So I really became involved in it probably about 2 years ago, around about now, in 2019, where a very renowned thoracic surgeon who's very well known, who I'd known in a former life as a trainee in cardiothoracic surgery myself, he approached me and said that he'd been seeing a group of conditions involving ribs which sounded like they were musculoskeletal in nature, and that he was looking for somebody who had some expertise in scanning patients who had muscle and bone and tissue problems with the ribs, or any type of tissue problems, and that he needed some support with that. So I admitted to him at the time that I'd never really done anything like this before. The only time I'd really seen rib injuries were in the setting of major trauma, so big accidents and diagnosing rib fractures, and in the context of putting in chest drains or taking fluid off around in the pleural spaces, but not really had any experience of scanning ribs per se. But what I did have was expertise in scanning joints, muscles, tendons, bones, and also an understanding of how to use different imaging modalities and an ultrasound.
Yeah.
So I took the challenge on. I thought, let's get on with it. And I went back to the basics. That's what you do when you're confronted with something that you don't really have much experience. So I went back to the books. I went back to the old anatomy books. In fact, I went back to Henry Gray's book, which was first published in the 1800s, because I love his descriptions. Some of the images I'd seen on the internet actually I've come to know are not very accurate, but Henry Gray's descriptions are just beautiful. And then I went back and looked at the chest with a completely new lens, a way that I'd never really seen it before. And what I saw were bones, cartilage, tendons, muscles, ligaments. It looked like a joint. And I looked at it as one big joint. And when you look deeply at the chest with that lens, then what you realize is actually it's quite a complex joint. It's got far more movements and far more complex movements than many other joints that we think of, like the hip or the shoulder, which we traditionally think of as joints. But it was quite tricky, really difficult, very, very stressful in those early days. And for that, I thank my patients.
Yeah, I agree. It's a stressful condition.
And for me as a health professional, I found it really difficult. But I thank my early patients. They were very patient with me. Some of those early scans would take an hour because I didn't... But when you scan with ultrasound, it's a bit like those 3D images. Suddenly you get that eureka moment and suddenly everything becomes clear and you can start seeing things. So what I started doing in those early days was just documenting everything that I saw. I didn't know what would be relevant, what wouldn't be relevant, and carefully documenting everything so that I could always go back to that and look back. Now, fast forward, scanning almost 200 patients, I've just seen so many different things, but that process still continues, documenting everything, looking back, and the most important thing is always having a self-regulator, internal regulator, where I look back and reflect every so often, in fact, very regularly, and think, am I doing this correctly? Am I doing this in the right way? Obviously, you've got some things that are out there in the literature, but not everything that I've read has been useful. Some of it's been excellent. But you have to have that internal compass to continually look back, reflect, think about whether you're doing the right thing, whether you've learned something is correct or not, and loads. I've learned a huge amount from, number one, the great thoracic surgeons I work with, but more than anyone other than patients. I've learned a huge amount from patients.
So from your very first scan that you did, was your approach, because there's a published protocol, isn't there? Is that where you started?
Yes. So in the beginning, it was very much just trying to get your eye in, just working out what you're seeing, what you don't see, counting the ribs, making sure you're at the right level. So it's all having a routine. So the most important thing whenever I do anything really is to have a routine, almost to the point of just I have to stick to a routine so that I keep consistent all the time. So yes, there were some protocols out there. I think there were, as I said, there are some papers that were less useful than others. There were some that were really good that I came across, that I then started to develop a different technique and started adapting it to the things that worked for me, that worked, and things that I didn't think worked so well. So yes, definitely you start with what's already there. There's no point reinventing the wheel, but as time has progressed, there's things I've learned along the way where I've adapted and changed and modified the technique to one that I think I'm quite comfortable with now.
Yeah, so you have scanned nearly 200 slipping rib patients now. Is there some sort of pattern or you know, what sort of range of severities and symptoms, anything that you can sort of enlighten us with that you've become aware of?
Yeah, so I have scanned, as you're saying, quite a large number of patients, and what started off initially as being virtually a slipping rib service, so the first group of patients, all I saw were just slipping ribs, which worried me because I thought, am I just calling everyone slipping rib? And then I went through this long period where I didn't see any slipping rib, and the service sort of evolved into more of this complex rib problem. So what sounded like slipping rib at the beginning turned out to be something completely different. And I had that period in the middle where you become quite worried that you think maybe I've lost my mojo on how to do these. But actually, when I look back now, that was probably one of the most amazing periods of learning, because I suddenly started seeing a huge range of problems: rib fractures, muscle tears, chondral fractures, cartilage injuries, so many different things that I saw. And I guess it just broadens the way that you look at the problem. You now know, don't just see it as a single entity, one problem, one diagnosis, out they get.
Yeah, those symptoms could apply to X, Y, Z.
Absolutely, absolutely, through to, you know, only one, but, you know, a tumour, things like that, people presenting with what sounded like slipping rib, like many others, but actually they turned out to have something else.
And how did those people end up with you? Had they seen a consultant that put them to you, or
so initially,
self-referrals?
Yeah, so initially it was all coming through thoracic surgeons who were very well renowned, and still that's probably the majority of the patients I still get now.
Yeah.
But as the information about slipping rib is now percolating through various different health professionals, the referral base has broadened. So now it's rheumatology, sports and exercise medicine physicians, primary care physicians. Any
from GI?
I haven't had one from GI yet, but I suspect that will happen at some point. But I haven't had any yet from GI. But the referral base has broadened, and there are some patients who then have reached out to me directly. So that's how patients have ended up in my place. There was the initial cohort where they were almost all slipping rib, had very similar patterns. Most of these patients had been undiagnosed for a long time, up to a decade in some cases. And that's when I see that first batch felt like a floodgate had opened, and all I was seeing was slipping rib one after another. And then as time went on, I was seeing more patients that sounded like they may have slipping rib, but it wasn't quite that. So when you look at the patterns of those initial patients, there was a recurring theme. These are patients who had gone through the healthcare system, seeing a variety of specialists: cardiac, GI, endoscopy, lower GI endoscopy, capsular endoscopy, you name it. Some people who had gone on to have gallbladders excised, hernia repairs, all sorts. And so they were a really interesting cohort of patients, and they were a group of patients that I really came to, they became quite dear of mine, because I really felt sorry for them. I really wanted to help them, because these patients had been through the healthcare system in its entirety and not ended up at an answer. Yeah. So that's basically
that. Really, yeah, that resonates. I think an awful lot of patients have had abdominal ultrasounds endoscopies, laparoscopies, etc. Because that kind of brings me to another question: is dynamic ultrasound the best imaging technique? Or, because a lot of people will have had CT scans or MRI scans or other kind of imaging done prior. Where do you kind of put slipping ribs, and what's the best approach?
So I'll answer that question in two parts. The first part of that question I'll answer with a broader brush, which is, what do you do with ribs? Which imaging modality should you use if you've got symptoms of rib pain of a variety of causes? With regard to that, I would say that all the modalities are useful and they all have their strengths and their weaknesses. It's very difficult to replace one modality from another to say this one is better. But so the skill of the radiologist is to try and understand the problem and choose the modality that is correct for that particular question or group of modalities. Now, there's no doubt there have been patients who have had ultrasound, CT, MRI, PET scans, and so on. And that's been entirely appropriate for them to have all of those investigations, because each is answering a slightly different question. So when it comes to modalities that you choose, you have to choose the right modality for that patient according to what symptoms they've had, according to their history. If it's a bony problem, for example, then a CT will be superior to anything. If it's a cartilaginous problem, then maybe MRI would be more appropriate. If it's a soft tissue lump or a mass, like a tumor, clearly MRI would be better. Ultrasound, dynamic ultrasound specifically, however, has an advantage over all of those modalities because it is, as the name suggests, a dynamic investigation. So for those patients that have a dynamic symptom, a dynamic pain, i.e. by that I mean a pain that occurs in certain movements, doesn't occur otherwise at rest, but it occurs with certain movements, when I twist, when I bend, then clearly an examination which stresses or brings on that particular symptom, an ultrasound would be better. But that said, there are times where I'll do an ultrasound and then I'll do an MRI for that same patient with a capsule on the skin marker where they've got pain, to see how the ultrasound correlates with the MR and whether there's an anatomical anomaly that would explain why such and such has pain.
Oh, so that's like a cod liver oil tablet as a marker, yeah.
But and then in the second half of that question, when it comes to slipping rib, now slipping rib, if that's what we think is the diagnosis, then clearly that's a dynamic problem for most people. For some people it's not, it ends up being a chronic problem where it's painful all the time. But for most people, certainly in the earlier stages, it's an intermittent thing that occurs, certain movements, certain positions, certain postures. So for that scenario, clearly a static examination like a CT or an ultrasound, like an MRI or an X-ray or a PET scan doesn't quite do the trick.
Of course, if you're lying down, the rib cage is expanded, and if ribs are tucked up and under, they're in a more normal position.
Absolutely. Now, we are working on doing some dynamic MRIs, and that's something that I did mention to you. So we are developing newer techniques where we are using the newer, faster MRI machines and novel sequences that we've developed and tailored for this particular condition to see whether we can simulate a little bit like what we can do in ultrasound, but in an MRI machine, because clearly the resolution of the image in an MRI is better than ultrasound.
So is that an upright MRI?
No.
It's still supine?
It's still supine, still lying down. The open MRIs at the moment just haven't got that resolution that we need. We need a really high resolution image for the chest. So we are working with that. We've had a few goes with it, but there's some work to go. We're making some progress with it, but we're getting there. I think when I think about the next 10 years, where will we be progressed in the next 10 years? I think the ultrasound, there's a couple of technologies that we have concepts that we're going to try and work with ultrasound manufacturers with to try and develop those. One of those is like a quantitative dynamic ultrasound. That's a concept we're going to start developing. And then I think MRI will really be, I think, one of the things that could make a huge impact.
So when you say we, who's we?
So we've formed a group called Rib Imaging, which is, we think, the first service which is dedicated to looking at ribs from a diagnostic perspective. That we've got a team of people that work here. We're working with our specialists in MRI, with our physics experts, engineering experts, and also from industry in terms of the ultrasound, to try and develop new technologies and new concepts based on some of the observations that we've made.
Pioneering with new stuff.
We'd like to think so. We're trying to put everything under one roof and really leverage our expertise in medical physics, understanding how imaging works, to try and manipulate that, to try and answer the questions that we want to answer, and then to set up some research. So we see rib imaging as having three main pillars. Pillar one is the diagnostic side, which is ultrasound, MR, CT, and the new techniques that we're using. On the therapeutic side, it's using things like the established techniques like intercostal nerve blocks and cryotherapy and trying to advance those. But the other half of that is to help our surgeons to plan their surgery more accurately beforehand so they have a really clear-cut idea of what they're about to encounter.
So would you say that a dynamic ultrasound, supposing you do a dynamic ultrasound, it's positive, how do you decide what's an appropriate action? Is it possible that somebody could rehabilitate themselves and stabilise those ribs without, or do you think, you know, where would you draw the line and say this person actually needs surgery, they need intervention?
So the surgical decision is taken by the surgeon and the patient together. I'm here to facilitate that for the surgeon and for the patient. So I'm sort of like the go-between, as it were, to try and provide an independent review, hopefully some objectivity and like a semi-quantitative, qualitative assessment of what the ribs are doing, whether they're moving, etc. One of the observations that we've made over the last few months is we've looked at, and really it's been the post-operative patients that really unlocked this, made me look at the whole condition in a completely different way to how I'd ever seen them before. And I stopped seeing it as just individual ribs, and actually seeing the ribs and the chest wall, as I talked to you, as a joint, but as part of a much more complex structure which involved the abdominal wall muscles, muscles of the back, movements of the spine, movements of the thorax. As we were talking earlier, potentially smaller muscles, maybe the diaphragm, lots of different structures that we've been looking at in a completely different lens. And that has led to a hypothesis, which we are testing, which is about whether it is possible in a group of patients, and not everybody, but in a group of patients, whether it's possible to rehabilitate patients to get them to a position where they don't have pain anymore. Because that's the most important bit, right? Whether the ribs are slipping or not, I guess in some ways might be irrelevant as long as you don't have pain.
So one thing that you've figured out how to do a pain injection as well, haven't you, in order to facilitate that? Because I know an awful lot of people with slipping ribs daren't do anything to do rehabilitation because there's not the guidance out there, and you know there's fear and avoidance involved in rehabilitation. You have to have the confidence to know that working through a level of pain is helpful, and if you think your rib cage is falling apart, then you're literally too terrified to do it. So if you can remove the pain, which you've successfully done now in several patients recently.
So that's an excellent question. So let's go back to the surgical element. The way I look at surgery now, and one of the greatest periods of learning is when I ruptured my ligaments a few months ago. Yeah. When I look at the surgery for my knee, and I'll use that as an analogy to explain how I see it applied to ribs. Yeah. When I look back at my ligament injury, I immediately started rehabilitation after the injury, within days of my injury. That led up to my surgical intervention. And then immediately after the surgical intervention, as soon as I was able to, I started my rehabilitation after. So when I look back at my treatment pathway, I see the surgery as an adjunct to my pathway in rehabilitation. So the surgery wasn't the focus of what I was doing. It was just a part of the journey of rehabilitation, the focus being the rehabilitation.
Which kind of technically, if you're going, if people were detecting this, if a GP was detecting this, the first port of call with the NHS would be to send them to a physio, musculoskeletal things, wouldn't it? So that element of whether you call it avoidance, because I mean, I did everything you could possibly imagine for a good year before I admitted that I wasn't going to be able to avoid surgery with this one. But you can build up muscles, or I mean, I know I had my surgery, and then the Saturday after my my physiotherapy was booked in, lockdown was announced, so my physio got cancelled. So actually for me it was a case of there wasn't physio available, but because I had spent a year trying to avoid it, I already had a good idea. So I made up my own hydrotherapy, did Pilates exercises, and of course I've done loads of reading on the different muscles and function, and many injuries are about getting muscles to work in unison with one another. So I've done rotator cuff rehabilitation before. So by my own knowledge, and YouTube's brilliant, I sort of pieced something together because there wasn't anything available, which actually is the case for most people. There's nothing available for this. There's no clear guidance.
I think that's a great point. One of the problems with rehabilitation is knowing what to do. And if you've been doing the rehabilitation of muscles or groups or tendons or joints that aren't necessarily helping, then it's very easy to lose faith and say, this is a pointless endeavour. So you've got to know what you need to rehabilitate, and you need to be working with the appropriate expert who then trains up what it is that you need to be training. That's point number one. Point number two is that there are clearly a group of patients that need to have surgery, in my mind. So a prime example is this: we have observed a subgroup of patients with slipping rib that don't have slipping rib, but actually what they have is a very unusual anatomical anomaly where the anterior portion of the rib is hook-shaped. It's quite literally a hook. And the hook then pushes on to the neurovascular structures.
So this is the cartilage at the tip of the rib.
It's actually a hook shape.
Yeah.
It literally looks like a fish hook. Yeah. And so when the patient gets into certain positions, it's not the slipping that's causing the problem, it's the tip of the cartilage that's pinching onto the nerve. Now, I would argue that you could rehabilitate that till the cows come home as much as you like, but the tip of that rib is going to impinge on those nerves. Now, clearly, in my mind anyway, I would think surgery is very appropriate. Likewise, there are a group of patients that we see that certainly need to have a surgical intervention to make this condition better, or at least facilitate their rehabilitation. As I said, this isn't to say surgery is not indicated. I'm not arguing that at all. Definitely there are a group of patients that need surgery. They're not going to improve without it. But it has to be thought of, in my mind, as a shift in the way of your thought process, I think, to using it as an adjunct to your rehabilitation. Yeah. So it's an adjunct in the middle of your prehabilitation and your post-operative rehabilitation.
So it's one piece, a very important and
very
significant
important
piece for a lot of people, but you need the physical rehabilitation either side.
In my mind, if we apply the principles of musculoskeletal injury of any body part, be it shoulder, knee, ankle, hip, whatever, rehabilitation is the focus of the treatment for that. And whatever you do in between, be it an injection, nerve block, cryo, surgery, whatever, and any other new therapies that we come out with in the next 10, 20 years, whatever therapies we come out with, in my mind, will be an adjunct to your prehabilitation and your rehabilitation post-operatively, and that will be a continuum. You cannot, in my mind, take one thing in isolation and think that's a silver bullet, we'll do that and that's it, your problems are going to go away.
So you have successfully relieved pain enough in some patients to try rehabilitation, and you've been speaking with a very knowledgeable physiotherapist. Is that how these patients, are they all going through this particular physio? Or?
No, so they're not going through the same pathway. Part of that is because there's a bit of a disconnect between some of the NHS patients we see and some of the private patients we see, and because on the private side there is a cost implication, not everybody's getting the same thing. So that's part of the things that we have to rectify with rib imaging. It's one of the things that we're going to try and rectify going forward to try and give a bit more of a homogeneous sort of uniform treatment pathway for people. But in terms of the nerve blocks, I mean, that's an established technique. I'm not going to sit here and say that I pioneered that technique. It's an established technique that we applied to this particular problem. We know it works in lots of settings, not necessarily for ribs, it works in lots of other conditions. But as I said, going back to musculoskeletal problems, if you can control the pain by whatever mechanism you use, and allow the patient to then do, be that tablets, ice, whatever it is that you use that allows you to control the pain, you create a window of opportunity to do your rehabilitation because it's less uncomfortable. And that's what we do with, I mean, again, going back to shoulders, that's exactly what we do with shoulder pains with people who've got tendon problems. Get rid of the pain, rehabilitate. By the time the painkillers are wearing off, or the block, or the steroid injection, or whatever it is that you've done, you have rehabilitated the muscle enough that it becomes less uncomfortable. And I can tell you on a personal level, that is what I did with my knee.
So did you had surgery?
I did, yes. So that's a prime example of where I had the option of not having surgery.
Was this recent?
Yes.
Because you don't walk with a limp at all. You wouldn't know.
I didn't walk with a limp within 7 days of my injury. And that was because when I went to the fracture clinic on that very first day, I went in expecting to get a big brace, crutches, and the surgeon said to me, you don't need any of that stuff. I'll give it to you if you want it. And I said, well, and he said, the best thing to do is to get going with your physio from now.
And you did, didn't you?
And I did.
You did hours every day, every evening.
Day, religiously, because one of my passions in life is playing football. And that's how I got the injury, and I'm desperate to get back to playing. And so I had my eye on the prize, and that's what I'm doing even now. The rehabilitation has been the primary aim, and as I said, the surgery is a very, very important part of it. I opted to have surgery even though I could have chosen not to, and it was uncomfortable and painful and all the things that people go through when they have surgery. But as I said, I see it as part of a much bigger picture.
I'm inclined to agree. And I think there are certain patients that are post-operative and they haven't necessarily had the same surgeries or surgical procedures either, but they have really, really dug deep into how to rehabilitate themselves. And they've obviously found physios that they trust and can work with. And they actually appear to be doing really quite well. And then, of course, younger people generally do better after the surgery, but equally, younger people do heal better. Than certain. I mean, your xiphoid, if I'm correct, is cartilaginous until now. I mean, I'm approaching 40, so mine will be hard and calcified. But is that around 18 to 20 that starts to happen? It starts to firm up and. So our physiology changes, doesn't it? So for potentially paediatrics, any surgical procedure could be easier, or rehabilitation could be quicker?
I don't know the answer to that question.
No.
I don't know the answer to that question.
No, it's kind of me going off on a...
I don't know. I mean, in terms of paediatric populations, this is a condition that in my observations, and as I said, it's just my personal observations, tends to occur towards the latter stages of your adolescence. So in bigger kids, I'm sure there are kids that are younger. I haven't seen younger children with this condition, but certainly adolescents and young adults. That's been my main observation.
Sporty as well, very active. Yeah. So I did actually read an article recently about a 6-year-old, was it 6-year-old kickboxer?
Wow. Okay.
That has slipping ribs. So it has presented itself, and obviously being diagnosed at that age as well, because I think I've had this since my teens. I was diagnosed at 37, 38 years old.
Well, I mean, your experience is what I would say is the more common thing that I've observed. It tends to occur in athletic populations, younger athletic populations, and tends to occur first when people think back. Certainly they mention their adolescence or late adolescence, but tends to occur, as I said, it seems to be a condition that affects active individuals rather than people who are inactive.
Yeah, I decided to refurbish a house myself. Self-levelling floors, ripping out bathrooms, and that was the final, that was it. My 10th ribs were wedged so far up and under, nobody dared try and tug them out again. So, sort of looping back, we were talking about your observations, and off the back of that, you're going to start a study. So
one of the things that we've been doing over the last few years is making these observations and some hypotheses that we've developed on the role that potentially abdominal wall muscles or thoracic muscles might play in this condition. We would like to test some of those hypotheses. So one of the things that we're doing at Rib Imaging is to put together a case for ethical approval so that we can perform research looking at what we think will be the broadest study looking at ribs across the spectrum, including healthy volunteers, so that we can better understand about normal rib anatomy, what happens, and looking forward. So we think that's going to be the biggest study.
Yeah.
We're going through the ethical process right now. That takes about 6 to 8 months to get the ethical approval for that, to design the study appropriately.
Right.
But we think we'll learn a huge amount for that. What I've done up to now is just to be in a series of observations. But what we need now is to have for that to be filtered through a real scientific approach, so that it's filtered through, so we can test it through statistical analysis, and rather than me or somebody else having a subjective approach to this problem, we have something a bit more objective that we can test and look forward. And I think we'll learn a huge amount from that.
So for this, surely you have to follow a very strict protocol in your imaging, so it's consistent for each. Have you got that already?
Yes, for slipping rib I have. So I have devised my own grading system. It was mainly for my own benefit, from a purely selfish perspective. So as you know, when I've scanned yourself, I have a system that I follow because I like to keep very rigid to my system, irrespective of what I think the problem is. So even when patients come with non-slipping rib conditions, I still follow my slipping rib protocol to rule out slipping rib, then look for everything else. So I developed that grading system, which I haven't published or publicised. It was from my own... Beg your pardon?
Are you going to?
At some point, once I validated it, definitely. Of course, the whole idea is to collect information, test it, validate it. Once it's validated, to disseminate it. But I guess the danger is that you look at a small cohort and you just publish it out there. It's much harder to undo something out there that you've put...
So is this potentially, you're thinking, if it's proved... through this research study, that is the point when you would publish your protocol and then obviously findings.
That would be the idea. I mean, the protocol, as I said, just was mainly for my own benefit, so that I would have consistency, and then I would know when I look back at an old study from a year ago, because I can't remember every single study, but I can look back at a study. If you look at the format of my reports, they're always the same. And I use certain buzzwords in my reports that I know are triggers for me to remember what I was trying to insinuate. So those are little sort of pointers for myself. So whilst I can't say, this grading system is the system that everybody should be using, I can't say that because I don't know. I could be completely wrong. But for myself, this is a really good reference point, and it gives me a framework with which I can compare one patient to another, or the same patient today to how they were a year ago.
See similarities in patients.
Absolutely. Yeah. If I'm using a haphazard technique, I'll never ever understand what I'm doing next. It just wouldn't work. So I had to do that. And so,
for me, I think that's beneficial because I probably will come back and see you again after my next surgery that's planned, and a bit of rehab, hopefully, and see what differences we see in mine. So
absolutely, look forward to it.
I'll make a mental note of what your protocol is. Try and hold you to that. Is there anything you think we've missed that you'd like to mention?
Yeah, I guess it's just to say that, look, this is a really complex group of problems. It's not a one-size-fits-all for everyone. Every patient seems to be different. There are obviously patterns that we are observing, and we try to link things together. But it's a really complex set of problems, and there are loads of unknowns. I mean, it's one of those scenarios where the more you learn, the more you realise how little you know and how many there are unanswered questions. For me personally, it feels like I'm at the foothill of this enormous mountains of unknowns that I just don't know the answer to. And that's a really important aspect. I think it's really important. There's been loads of times in the last couple of years where I've had to say to patients, I don't know. I don't know the answer to you. I don't know the answers to everything. And I don't know what's wrong with you. What I do know, it's not X, Y, Z, but I don't know why you're having this pain. And it's really, you have to overcome that feeling of, I guess, inadequacy or pride or whatever that might be. But I've always tried to be really transparent and open with patients and say, look, here's something I do know and here's something I don't know, and I don't know the answer to that question. It doesn't mean I'll never know. It just means at this moment in time I don't know the answer to your question, and maybe in the future I will. But you've got to have that process of having a framework that you work within. And that's what we're really trying to do with rib imaging. What we're trying to do is to create frameworks, governance, test, sort of an infrastructure which allows development beyond me as an individual.
Yeah.
But it could be people outside, other people who join the practice in the future, or people who take on this work after I'm gone.
Yeah.
But we build those infrastructures, the governance systems, so that we're testing all the time. And the aim is to just be progressing all the time. That's the objective.
Quantifiable data.
Absolutely. Looking forward, how can we be progressing all the time in this, rather than we've figured one thing out and we're happy with that, but actually we're continually looking back and saying, can we do that thing better? Is there something that we can improve in X or Y or Z? To do that, you have to create an infrastructure rather than just a guy in an ultrasound machine scanning patients one after another. So that's what we're trying to do.
The scale as well is important at that, isn't it?
100%.
Because I mean, everyone has a unique fingerprint, everybody in the world. So all of our bodies aren't made up the same, but hopefully there's enough consistencies there to really iron out your diagnostics.
100%.
Before meeting with you, I put out on the social media platforms and I've had quite a lot of people come back with some questions. So I've tried to collate them. I think we probably answered an awful lot of them already. One of the questions that has come in is digestive issues, because a lot of people do seem to have these symptoms. And obviously part of the diagnostic or the symptoms are that most people have ruled out pancreatitis, like you said, gallstones and that kind of thing. So have you got any observations that would indicate why those symptoms?
So in my personal observation, it's not something that I've seen lots of. That might be my fault because I don't ask the patients directly and I haven't challenged them about it. It could be because when the patient comes for their scan with me, they don't think it's particularly relevant because they've already ruled out the GI stuff. So in my personal observation, it hasn't been a recurring theme that I've observed. I don't have an answer. I don't really know. Is it neurological? Is it connected to the autonomic nervous system? I don't know. These are one of those questions that we need to look forward, start seeing patterns and potentially exploring why that might be the case. But as things stand right now, no, it's not certainly anything. I haven't got an answer for that, no.
Well, so, I mean, these questions actually, they flow into one another quite nicely. I'm not sure we've quite answered them. So are you aware of any other radiologists that are accurately performing dynamic ultrasound in the UK?
So there's no network of radiologists that I know of, as far as I'm aware, where we're networking with one another to know what each is doing. Right. So the only time I ever really come across other radiologists is by chance when I see reports of patients that have been scanned elsewhere. And gauging from what's written on the report, it looks like there are people out there who are very skilled sonographers who have some understanding of the condition and are performing good ultrasound scans. I can only judge by the report. I'd be quite depressed to think I'm the only person doing this.
So there's not many musculoskeletal specialised radiologists, though, are there?
There is a decent body of people, but as I said, there's no network for me to be able to gauge who's doing it. But I would hate to think I'm the only person out there that's doing these, or the only person that can do these. I don't think I have any magical skill. I'm certain there are other people that can do this scan just as well as I can, maybe better than I can.
Okay, and I guess, are you aware of this being available on the NHS, or do you think potentially it could be made available on the NHS?
So the majority of my working week is spent in the NHS. That's the vast overwhelming majority of the work that I do, and I have scanned patients on the NHS with this condition. The NHS is patients. It can be quite difficult because, as we've discussed throughout this discussion, this is a quite complex problem that has lots of facets to it, that needs lots of specialties to be coordinating with one another. So it's been quite difficult, or it can be quite difficult and challenging to coordinate all of that under one roof. Yeah. As things stand, it's the way that NHS structures are built and the funding follows the patient. It's not possible for a surgeon in one hospital to refer to a radiologist in another. So it makes it much, much harder for us to coordinate the care. And particularly if you then go on to have your surgery in another hospital, it makes it impossible to be able to scan that patient post-operatively if the patient remains an inpatient. So for that reason, that's been a massive drawback, and why perhaps the availability in the private sector has been much faster, quicker, better coordinated than we can. it takes time with small conditions like this for the information to get out there to commissioners and among the medical fraternity, that then you can produce networks and pathways, etc. That's going to take some time. It's something that we have to work towards.
I think it's spreading. It definitely is spreading.
Yeah.
I've been on this journey for 3 years, and there are 3 thoracic consultants that weren't doing these, I don't know, minimally invasive procedures even 2 years ago.
Yeah,
basically.
absolutely.
So
absolutely.
Word is spreading, and I think every patient that sees somebody then sees somebody else and then finds out, and then they're spreading the words individually. I know that I've introduced dozens of people that physiotherapists or acupuncturists or doctors, GPs.
Well, your
They've never
Facebook
heard
group
it.
has been amazing, I think, in disseminating information. I think that's been a really valuable tool, and loads of patients that come to me are really well informed, which as a doctor makes a big difference from my point of view, to have patients who know. Actually, it's been really educational for me, who challenge me basically. They come in and they say, what about, you do. Who will say to me, well,
in a very nice way,
well,
hopefully.
Dr. Abbasi, are you sure about that? And I was, I didn't really know that, actually. That's a good idea. I'd never thought about that. And that's
nothing
really...
like a selfish motive behind things to find out. So that's obviously NHS. You are working in the NHS, so that's a catchment issue, is it? Only people in catchment?
Yes and no. In the initial periods, yes, it is purely catchment. Yeah. But as time progresses, as knowledge grows, and then there's a body of information that part of the thing is that you have to be able to go to commissioners with a body of knowledge to be able to say, here is a condition, here is a problem, here is how we're going to solve it. Yeah. And that's why there should be money made available for this problem. And so we need that information. It all goes hand in hand, basically.
Presumably, after this study that you're looking to do, and you are hopefully going to publish your findings and potentially a protocol, etc. Is that, at that point, do you think that you would be looking to train other radiologists?
100%. That's exactly the object. That's why we're forming Rib Imaging, is for that particular purpose. We want it to become a centre of excellence in terms of knowledge, accumulating that knowledge. And then once we have cracked a system, we're sure that it's the right thing to be able to disseminate. Of course, that's exactly that's the whole purpose of making this whole thing, is so that we can disseminate correct information out there to be done in the right way. Yeah.
So I guess a really nice one to leave you on. Is it possible that with a dynamic ultrasound, you could still miss slipping ribs?
The answer to that question is, I think, almost certainly yes. Firstly, no test is 100%, so every test has its drawbacks. Ultrasound is very user dependent, so it's very possible for you to miss something. I'm just a guy who's just scanned a group of patients. I don't think I have the answers to everything. So is it possible for patients to miss, for me to miss slipping rib on cases? I think it almost certainly is. It's probably the thing that keeps me awake at night and keeps my feet firmly on the ground, knowing that I don't have the answers to everything, that I'm not some sort of oracle or messiah on this area. But all I can do is to commit myself to the patients, commit myself to learning and getting better and improving. That's my commitment that I can make, and that's what I'm committed to doing.
I mean, I've got to say that your dedication and commitment to researching it, and you're very passionate about it, and that's something that, as a patient, I'm so grateful to meet you, to speak to you, hopefully share all this information with the community on social media, and it's excellent. And hopefully at some point we might be able to do a follow-up.
100%, I'm more than happy to do that.
Maybe in a year when you've got everything rolling, that would be amazing.
I hope I've got something positive to feedback to you at that point.
I'm sure you will.
We're working really hard. That's all. We're working really hard to try and solve this problem and do the best we can for all the patients.
Thank you very much.
You're very welcome. Thank you very much. It's been a pleasure.